So first off, we have Aza Nedhari, who is a midwife, a family counselor, and executive director, co-founder of Mama Toto Village, a perinatal family support organization here in Washington, D.C. that has been successful in securing Medicaid managed care reimbursement for non-clinical perinatal support services. Aza has also designed a comprehensive training utilizing the community health worker model as a blueprint. This program is designed for perinatal health workers through 1 year workforce development program. Aza is currently pursuing her doctorate in human services with a concentration in organizational leadership and management with an eye towards cultivating innovative models of perinatal care delivery in high-need communities. Next, we have Ms. Breana Lipscomb, who is from the Center for Reproductive Rights. Breana joined the center in 2017 as the U.S. Maternal Health and Human Rights Campaign Manager. In this role, she develops advocacy campaigns to promote Black maternal health, particularly in the South, and she works to mobilize a broad base of stakeholders, including policymakers, reproductive justice advocates, public health professionals, the medical community, and others. And in this work, she advances state-level policies that further reproductive rights as human rights. And last but not least, we have Linda Goler Blount, who is the president and CEO of the Black Women's Health Imperative. Linda joined the organization in 2014. As president, she oversees the strategic direction of the imperative and is responsible for moving the organization toward a mission to achieve health equity, reproductive and social justice for Black women across the lifespan. Prior to joining the imperative, Linda worked as vice president of programmatic impact for the United Way of Greater Atlanta, and she has also worked across the public, for-profit, and nonprofit sectors. So let's get on to the panel. Okay, great. So there's so much to digest, I think, from the film. There are so many different themes there, so many different aspects, I think, of this issue. I think, saying it's complex is an understatement, but that doesn't mean that we can't work to address the issue. So in the film, we heard the theme of racism and structural racism come up. So I wanted to ask Linda, start off with you, what is structural racism and how do Black women experience it in the U.S. healthcare system?
I suspect most of us have felt it, even if we couldn't name it. So just before I answer, just a quick question. Was there anybody in the audience who wanted to scream and cry and yell? Oh, okay. So it wasn't just me.
Yeah, yeah.
So our healthcare delivery system was set up a certain way. And the way it was set up was not designed to actually help women like us. Think about the hours that you can go see your obstetrician and your gynecologist. You're not seeing that person on Saturday. You're not seeing that person in the evening. The kinds of processes that we have to walk through, the expectations are based in a culture that doesn't value ours. So a Black woman can go into, and I've seen this many times, to see her obstetrician, and the first question she may get is, did you expect to have a baby? Did you plan to have this baby? Right? What kind of question is that? So already she's put on the defensive. Already she's being made to feel as though something's wrong. And so the system is set up for providers and payers. It's not set up to produce great birth outcomes for Black women and for marginalized people in this society. And within the system, then you get sort of the interaction. Black mothers are not offered breastfeeding services nearly at the rate that new white mothers are. We're not encouraged to do the kinds of things that would make us bond with our children. You heard on the movie, I didn't get to have that experience with my newborn that I expected to have. I can't talk about that. So the way we are sort of navigated through the system isn't designed to help us. And, of course, if things go wrong within the system, we're there yelling, Serena Williams, others, something's wrong, and people aren't paying attention to us because the assumption is, well, they don't really know. They must not really know. Serena Williams, as she said, had to get an attitude to get some attention, but someone like Kira Johnson, who also complained for hours, when they finally got to her and found 2 liters of blood in her abdomen, it was too late. She left an 18-month-old and a 1-month-old.
And I think another key piece from the film is the trauma component in the birthing experience, which really hit a nerve for me. You know, knowing that women are going into a hospital expecting to have a lovely experience birthing their child, because that's what we all sort of strive for, right? And they go through these really traumatic experiences. So even if they do come out of that experience and make it through and they have a healthy baby, I mean, that is something that is going to stick with them forever. So I can't even imagine. And so, Breana, a question for you. In the film, Dr. Jackson describes the double jeopardy facing Black women, and how does race and gender intersect to complement, or to not complement, to complicate maternal health issues?
Yeah, you know, I think about this a lot, right? So being a Black woman, you know, when you think about marginalized groups in the U.S., I feel like for a Black woman, it's the worst of both worlds, right? We're Black, so we're dealing with the structural racism component that Linda spoke about, and then we deal with all of the gender oppression issues. So I'm not going to rehash all the structural racism piece, but then with gender issues, particularly under the current administration, there's constant attacks to access to sexual and reproductive health services. Pregnant women have, by and large, particularly in hourly positions, but also it's across other career sectors as well, there just simply aren't the appropriate accommodations in place for pregnant women in the workplace. We have the woman tax, where we're having to pay crazy prices for shampoo, tampons, I mean, just regular things that we need. They cost us more. We're not getting paid the same. And God forbid you're Black and you're a woman, you're definitely not getting paid what you could be. So when you think about all of that and how it impacts our maternal health outcomes, it's all interrelated, right? So if you think about a woman that doesn't have paid family sick leave or can't even take sick leave for herself, then she's having to make decisions about, well, do I just not go to work today and then perhaps face not even having a job after my medical appointment, or after I deliver, am I having to go back to work a week after I deliver, or perhaps even sooner than that? I mean, these are the types of things that we not just have to deal with, but we also have to think about it. And so that is adding on to that chronic exposure to stress, which is directly impacting our health outcomes as well as our mental health as well.
Right, and we saw the story from the woman Sugar in the film, who talked about having to go back to work after 2 weeks of giving birth. And so just to imagine like all of the stress and strain in terms of her family life. She also mentioned that she had like 8 kids, I think it was. And so that coupled with the newborn and then having to go back to work you know, so soon after giving birth, you're absolutely right. The stress associated with that can compound the situation. And so, Aza, we've talked a little bit about, you know, the biases that we see in terms of providers when they're working with Black women sometimes. And what have you seen in terms of the work that you do with women? You know, have you been with a woman, you know, on a visit and sort of seen any of those unconscious biases sort of percolate in the context of any visits they're having with providers?
Yeah, so I actually don't do provider visits.
Okay.
No.
Okay.
I'm more of the administrative side.
Okay.
But the stories that we hear
Yes.
are that that is something that's a constant throughout the experience of that woman. And one of the things that we do is that we capture from the woman's perspective her experience with the provider. It's one of the surveys that we do. So we look at, there's one during pregnancy, I think it's called Your Provider, Your Pregnancy and You. And then on the postpartum end, once she's had that baby, we capture more information. And then we share that information with the MCO because we feel like it's so important that they hear what's going on from the mouth of the mother and not always from the mouth of the advocate, right? And so a lot of work that we do beyond just helping that mother with navigation is advocacy. So when that mother is in a space where she's not being trusted and her voice is not loud enough to be heard, we kind of step in and make sure that her concerns, that her needs are centered, and professionally calling bias, to the floor. And, I think the other thing that I see that consistently happens and that shifts culture within those environments is that the workers demonstrate for and model for the providers how to care for that woman, right? And sometimes our actions are much louder than our words when you show as opposed to tell, right? Because sometimes when you're telling, people don't listen, but when you're showing and you're demonstrating, it's much more powerful because then it calls that person out and makes them look like the odd man out when everybody's being nurturing and caring and supportive and, the other person is being other than that.
Well, it's interesting. I mean, just to piggyback off of that, I mean, clearly we have a situation where, the care is not woman-centered. And so what can we do? And I think that OBGYNs can learn a lot, particularly from the work that midwives and doulas are doing. And so how can we begin to sort of shift things in terms of having, OBGYNs have more women-centered care, particularly for Black women, because we know that maternal mortality is such a major issue within our communities.
Yeah, so I am of the light that we should be centering families and not just the woman. Like the woman is important, but the woman exists and is best understood in the context of family, right? And I think that the models in which we have always exclude when that woman has a partner. That partner is very excluded from that dynamic, and the partner is marginalized in that dynamic. And if we're thinking about building healthy families and healthy communities, if that partner is not included from the beginning and brought into that fold and made to feel accepted and a part of, how do we expect this person to then go and be a father or a mother if it's the same gendered couple or whatever, however people are self-identifying? Like, how do we expect that to just magically exist when that's not nurtured and cultivated during the perinatal period? Parenting starts at the moment of conception. That baby is a sentient being, and they're pulling and grasping from the experiences that are happening outward. And so I feel like from the role of the provider, it's their job to nurture and cultivate that space so that that woman can bond and connect with her baby, that partner can bond and connect with the experience. And so you asked, how do we do that? I think it just starts with building a connection, right? And so much of us can remember going to our providers and it's cold, it's sterile. Yeah. It's like we have 10 or 15 minutes. I have to ask my questions and we have to kind of get out. And you asking questions seem to be a nuance. It seems to agitate. And I think just building connection is at the root of any relationship. And so I think beginning, I was on another panel, I'm like, we have to just start asking simply, how are you doing? How are you feeling? How is this going for you? Not, let me check your belly. Has your baby been kicking? Have you been eating well? That's all nice, but just how is she doing as a person that's sitting in that chair, not her as a pregnant body, right? So.
Yeah, that's so compelling. Did you have something to
add? It's a challenge because when the provider asks that question, and the mom says, well, now they've got to do something.
Right.
Got 8 minutes for this encounter. I'm not going to be reimbursed for but that's exactly the kind of care that should be provided.
Right. And I mean, honestly, all of us, right? I believe people just ask how you're doing because it's nice, but nobody really wants to know how you're doing for real. But, asking someone how they're doing, right? You can literally identify for, like, we have 15 minutes today. I wish I had more time with you, but I do want to know, how are you doing? How are you feeling? And it literally takes 2 minutes to listen to her heartbeat and measure. That takes no time. Maybe you can do it in 1 if you touched enough bellies, right? But asking her how she's doing is going to elicit so much more information that's going to allow you to give her better individualized specific care. And I don't believe that it's the role of the provider to play social worker. You have other entities and community resources for that, but they should identify this woman needs more help. Something's wrong here. Let me pull in some other people.
Right, at least being able to connect women
Exactly.
to what those other services are.
But if you're not asking a question,
right,
and you're only focused on her as a pregnant body, not her in the entirety of herself as a woman, then that's not going to be important to you. You're not going to prioritize that.
And I think I think initially I had asked you that question because I was on a panel last week with one of your birth workers, and she was amazing. I cannot remember her name, so excuse me, Breana, yes. And she talked about, Mama Toto is just doing some really phenomenal work. So if you all aren't familiar, please Google them and look at the work that they're doing and the support that they're providing for women in the district. And one of the things that really stood out to me was she talked about the homelessness issue, and that I think she said 1 in 3 of the women you serve are homeless. She mentioned one young woman that was living on a bus for like 4 weeks, and so I would imagine that the women that are providing these support in your organization have to be strong within themselves to be able to help ensure that these women are getting the support they need, not only in terms of birthing their child, but also the wraparound support that they need. So, organizations like yours are really helping to fill a void, especially in high need areas. So just wanted to point that out because I've been thinking about it a lot since I met her. So I'm like, how can we do more to support this organization? So thank you. And then I also wanted to ask a question, and this is for either Linda or Breana. How does maternal mortality among Black women affect communities of color more broadly?
Fill in the blanks.
Yeah, I think that's a great question. And really building off of your response, I think that anytime a woman dies, particularly a Black woman, you're dealing with a family that has experienced a loss, a child that no longer has a parent. So there's those issues. But then I think, as we saw with the mother in this story who lost her daughter, when it's something that is preventable, it creates a lot of questions, and then often questions that go unanswered. And then that increases the mistrust of our providers and of the medical system, right? And then it's just another cycle of people choosing not to access care because they don't trust the people that are delivering it to them. And it's care that's not being offered in a compassionate way. So when I think about the impact on the community, I have to think about that. The other point I want to raise that was also highlighted in the video is thinking about, yes, we have this issue with maternal mortality, but then think about severe maternal morbidity. So these are women that are having serious complications with their pregnancies and their deliveries, such that it is creating some major issues for them later. Some women end up on a ventilator, some are having to have hysterectomies. So then you think about the impact of that on their communities and on their families. And severe maternal morbidities are 100 times more common than a maternal death. So it's like you're having to think about it all together. And I think the impact is that it's happening in the communities, and the communities are left having to deal with it. Either a woman has died or she may have some long-lasting medical issues as a result of it. And then it's just like you're just left holding the pieces with no real answer as to why this happened or what can we do about it, and no policies in place to help move things forward. So I don't know.
And to your point about trauma, there is no more traumatic event than to lose your mother.
Mm-hmm.
Imagine, the children never know what this is like. And in some instances, the family's got to step in, but sometimes the family can't step in because there are no resources. So the children, this newborn or brothers and sisters, end up being placed, worst case, maybe with people they don't know or who don't particularly care for them, or with relatives who then may not have resources, who may then understandably be angry and resentful about having this additional financial burden. And I'm sure you all are familiar with ACEs, Adverse Childhood Experiences. These kids grow up and they're the ones who get disciplined at higher rates, drop out at higher rates, are more likely to live in poverty, and of course we know the cycle. A child born in poverty has a slim chance of ever leaving poverty. Atlanta is featured. Atlanta is one of the worst places. A child born in poverty in Atlanta has a 4% chance of ever getting out of poverty. So when you start out that way, it's really hard to overcome, and it's perfectly understandable then when you see what happens with children and as they become teenagers and adults, because they didn't have the beginnings that their mothers would have wanted. And to your point, Breana, especially if it was preventable.
Yeah. And we know that 60% of these cases are preventable.
Absolutely.
To add on to her point too, that children do know. And there's a branch of psychology, it's called pre and perinatal psychology. There's an organization called APA. But there's a lot of research about the baby's experience of birth. And that the babies do know, and they grow up to be anxious adults with mental health issues. And under hypnosis, those people usually recount their birth experiences. And so I believe that, I always ask the question, like, what type of people, what type of adults are we creating, right? What type of humans are we sending out into the world, compounded with those adverse childhood events, right? Compounded with not only did my birth experiences begin as trauma, but then I layer that with, now that I'm here, there's more trauma that kind of adds on to that. And so you get an individual as an adult that exists when I call a trauma tornado, right? They're in this cycle of complex layered trauma that then manifest as mental health issues. And we're like, well, something's wrong with this. Of course something's wrong with them. They started in a place that wasn't optimal, for their well-being.
And I could imagine too, we also talked about the mistrust of providers. And so I can imagine, with the family, having, if a mom is lost, and having conversations about, what happened or didn't happen in terms of her birthing experience, and that contributing to this generational mistrust of providers is also a piece of that. So one of the things that we also heard in the film, and as well as in all of the literature much of the literature about this issue, is the fact that when we control for education, income, this is a problem for Black women, pretty much across the board. And so I think in terms of the conversations that we need to have about policy solutions, at least in my experience, when I go to these panels or listen, to folks talk about this issue, they bring up that fact, but then the policy solutions are really targeted on, low-income women, and we need to expand Medicaid, we need better access to Medicaid, we need to have, poverty alleviation initiatives. And the women that are in the middle and upper income areas, or spectrum, we're not talking about policy solutions for them. So just wanted to see if you all have started to think about that, and if so, what do you think? I know here at CAP, it's something that I am struggling with as we continue to delve deeper into this work. What do those solutions look like for us to really get at those women in those, parts of the population?
Wouldn't this be a great opportunity to have some more public health education in medical school? Or just require all medical students to get a degree in public health.
Mm-hmm.
Yeah.
But there's practice implications. And, my daughter's best friend, Georgetown attorney, delivered her first child at 22 weeks, 1 pound, 4 ounces. It didn't occur to her OB to ask these kinds of questions because, she's this professional, highly educated woman. On the second child, of course, all precautions were taken, but it just seems like some basic epidemiology needs to be communicated so doctors can at least ask some additional questions. It's not, you'll hear people say, well, that's profiling. I don't agree with that because the data support the need to pay additional attention to Black pregnant women, especially if you think about the lived experiences of Black women. And if you think about Arlene Geronimus's research, where she talks about weathering, so she's looking at the effect of racism at the DNA level. So we know that this is real. How difficult can it be to ask some additional questions? Keep a closer eye, change your practice. Well, maybe you should come every 2 weeks instead of every 4 weeks. We need to keep a closer eye on you just to make sure that this mom has the healthiest birth outcome and maternal outcome possible?
I don't have an answer for this, but but it's something that I think in your response, I think you hit the nail on the head when you said listening to women and their lived experiences, and that's the piece that's missing, right? So even though you have all of these states, some have had their maternal mortality review committees in place for quite some time, some are just recently implementing them, but a lot of those, it is a bunch of white male doctors sitting around a table reviewing medical records. No community representation at the table whatsoever. No one really giving any sort of context to the case other than what's just written in a medical record. And so I think it's easy, even though we know the data reflect that poverty is not what's driving the maternal mortality rates. But when you ask those additional questions, then you have to address the responses that you receive. And so I think a little bit of it is they don't want to open that can of worms and have to address the root issues, one of which being structural racism,
right,
and how that manifests in the policies, in the institutions where we access services. So it's not an answer to what kind of policies we need, but I think the number one thing we can do is to really start engaging the community in a meaningful way.
In the MMR committees, they also don't want to address provider bias.
Right.
Right, exactly. Exactly.
That's what I was going to mention, that I think solutions come from the systems of engagement. Like where women are going to seek care is where the change needs to happen. Because you can make a law, you can make a bill, you can mandate.
Don't know, implementation is another story.
But
yeah.
if education, I feel that medical students are not being trained well. You get trained, you can learn clinical skills, you can learn a clinical skill, you can study enough to learn a clinical skill, but you really can't in a 2-year or even come to a cultural competency training and unlearn how to not be racist, right? Like that takes some heavy work within yourself to do that and understand the lived experiences of someone else. You can't be competent in a culture that's not your own. You can engage that person in a culturally humble way or a culturally empathetic way, but you can't be competent in culture, It's not a learned clinical skill. And I think that was created as a way to gloss over. It's an and, right? Like, oh, I'll just take this I'm culturally competent. No, you're not. You're still racist, right? You took this training. But I think it's really important on a policy, on that institutional level, that within education, students should be required to work within the communities that they want to serve and that they intend serving. Like they should have to go into communities, work in a clinic, do community access walks, see what the people that they're serving deal with, engage in more ethnographic experiences, and have it be a really authentic experience, and understand and learn like all of this, all the things that are being presented by Black Mamas Matters, that should be built into a curriculum. It shouldn't just be, and that's the public health piece, right, that she mentioned. I don't know if they need a degree in it, but I do think like those pieces and that legacy of racism that has been ingrained in the fabric of this country and that has been a part of the reproductive narrative of Black women since the inception, that needs to be what's taught. It needs to start there and bring it all the way up, and people can see like what is the connection between then and now, and where did all of this come from.
Absolutely. And there were definitely some good pieces. We just ended Black Maternal Health Week, which was April 11th through the 17th. So if any of you have been under a rock for the past week or so, but I doubt you have, there are so many good, rich readings out there for you to delve deeper into these issues, really dealing with, specific aspects of Black maternal health, even some pieces sort of getting at the root of some of the historical foundations of the lack of reproductive freedom for Black women in this country. So urge you all to go out. I think you can still follow the hashtag Black Maternal Health Week or Black Mamas Matter. Follow them on Twitter and you'll find some good stuff there. So we have a few more minutes, and I wanted to shift to audience questions to see if folks had anything they wanted to ask our esteemed panelists. in the back. Let's start back there and move up.
Hi, Rajani Frederick. I'm probably taking up this time with the Center for American Progress. But I have a comment / question for you all, because this topic is just so relevant in my personal life. So this past weekend, I visited a good friend of mine who had just had her first baby. She lives in Upper Marlboro. So we get there, we see the baby. He's beautiful. She looks so tired, and then she immediately begins to confide in me about her birth experience. Essentially, she was in labor for a full week. Went to Anne Arundel Hospital, I'm gonna call it out, and each time they sent her home. This is her first child. She's Ghanaian American, first generation. She can't understand. She's in the worst pain of her life. She said, I wanted to die. Kept going back to the doctor. They kept sending her home. Finally, because she wasn't dilated, they gave her 2 epidurals that wore off. I mean, it was just wild. It got so bad that literally her husband and her had to drive all the way to Howard. And you know the first things that she said when she entered the ward, actually, they said this to her. They're like, thank you for bringing in new life. Thank you for bringing in the next generation. And she was like, I'm home. So it was so profound how incredibly different and disparate her experience was versus Anne Arundel versus Howard University. And so that just made me think about what are the countless other examples. Have you heard similar stories? I mean, to be in labor for a week and to be constantly sent home because she wasn't listened to and because they were just looking at how dilated she was or whether her water broke. So how often have you heard that story or similar stories?
Yeah, I mean, that's not uncommon. It's not uncommon because, again, you know, women are viewed as machines that just push out a product, right? And so when you're viewed as a machine, dilation or labor and birth is not exempt from that experience. And so the belief is that, oh, dilation is a direct correlation to how far along you are in labor, right? And I'm like, that's not true. Some women start labor at 8 centimeters. They're not in labor yet, right? But I think that's why support and advocacy is so important for women of color when they're showing up in these places, that they have somebody who's knowledgeable, because it sounds like your friend actually had a baby that was not in the optimal position, right, for birth. But had her provider educated her about that, you know, she would have known to do something different with her body to facilitate making more space for her baby, right? And so it all ties back into what type of care are women receiving that allows them to have more positive birth experiences. But it's not uncommon for a woman to be, I had a mom that was in labor for 5 days.
She's traumatized. Like the number one comment, she was like, I'm not going through this again. I refuse to have a child.
But I mean, you know, the difference between that mom and your mom is that she had a lot of support and we normalized that experience for her, right?
Okay, over here. Were you? Okay.
My name is Ashley, and I'm with an education organization, but I am also a new birth doula. So I'm very interested in this topic. And I guess I had, the entire time I was watching and the entire time I've been listening, I've been thinking also, like you were saying about what can we do, like at like a policy or a, not like policy government, but like hospital policy kind of thing. And I remember one of my friends is a doctor in England, and he splits his time between England and the U.S., and his wife is an American citizen, and he says he'll never let his wife give birth in the United States because the baby comes first and the woman comes second, whereas in England, the woman comes first and the baby comes second because the woman can always have another baby, but the baby will never have another mother, and that's their angle. And I wonder if we changed how we think about women and put women and have doctors put women first as their like actual like hospital policy and what they learn in medical school, if that could maybe help change the culture around it, and if you've heard anything about that or have any feelings about that.
Wouldn't it be nice to center around a woman?
I mean, good luck. I mean, I would say, I mean, even just in the work that we've been doing with Black Mamas Matter Alliance, it has been really interesting to me the number of conferences we've gone to and talked 100% about the mom, maternal mortality, and then the first question we get is, well, what about infant mortality? And it's like, well, we've been talking about infant mortality for quite some time. There are a lot of resources put into the baby, which that is awesome. But for once, can we focus on the mother? And so I think a lot of the work that Black Mamas Matter Alliance is doing, as well as other organizations like the Center for Reproductive Rights, CAP, I mean, it's continuing the conversation is an attempt to shift that culture, right? So not just talking specifically about Black maternal health, but maternal health in general. We have to stop thinking about the mom as a conduit for a baby, right? Can we just value her for who she is for once? And I think that once we start centering the mom, we will start hopefully seeing some better outcomes.
And I would say too that I think to add on is that the mom and the baby needs to stop being looked at as separate entities. And like the mom and baby have a symbiotic relationship and one responds to the other, right? So if mom is stressed, baby is stressed. If mom is happy, baby is happy. And so I think not seeing, because I think both sides are off. I think that mom and baby, which is what Mama Toto means, it means the connection between mother and baby, like they're a pair. And when that mom dies in childbirth, that baby is profoundly affected. And when that mom loses her baby, that mom is profoundly affected and she never gets over that experience, right? Like, yes, she can go on to have another baby, but when women don't resolve the trauma from a previous loss that she had, no matter how early that loss, that carries over into the next pregnancy. And what they've shown is that that mom is more likely to have a preterm delivery with a subsequent pregnancy when she's still grieving the loss of that previous child. So just recognizing that the two are one, and if we treat them as a pair and we wrap around both of them and stop trying to segregate them out, as well as the woman in the context of her fullness as a woman, I believe that would breed better outcomes.
Wouldn't it be great if we could teach value?
Right.
Because we take care of the things we value.
Right.
And if we value
Absolutely.
the Black woman,
Right.
instead of seeing her as this vessel that is only good for irresponsible reproduction, which is what happens.
Right.
I mean, I've literally been in hospitals where right after the delivery of the baby, the OB is talking about larks because we don't want that to happen again. I mean, what kind of message is that to send to a woman? This is one of the most beautiful experiences of her life, and now you're talking about how I'm never going to do this again. So how about starting with value?
There's lack of value in both, like mama and baby, a Black child and a Black mama.
Yeah.
Perfect segue to my question for you. So I'm the Chief Policy Officer at 0 to 3, where we focus on infants and toddlers and policies for families. But I'm really sensitive to your point that we have been focusing so much on the infant and to the exclusion of the mother. And so I really appreciate your comment that it is a dyad. We talk about the dyad, early connections matter. So I'm wondering what, from the policy perspective, what we can be doing on the baby side to really support and hold up mothers. Because we do have, it is easier to think about infant mortality. There is more support. We do have the wind at our back in some ways. We're very far from let's be clear. Black infant mortality is a crisis in this country too and should not be ignored. But how do we lend the support that we have to hold up this work? And how can we work as a dyad? And what are the policies is really what I'm really thinking about. What are the policy ideas that we should be tackling together?
Well, I mean, a couple things that come to mind, and I'm sure if I had more time, I could come up with more. But I know, for example, I mentioned paid family sick leave, right? So that's a major thing that if a woman is able to take time off, either for her own care or for her child's care, those are major benefits. And then also when we think about access to care, I know we focus on that a lot, but particularly, and we're not going to go down the poverty track again, but I have to say, when you think about women that are eligible for Medicaid and the fact that it ends 60 days after she delivers, that tells her we don't value you other than the period that you're pregnant, and as soon as you deliver, we're going to get you in for your postpartum checkup, and then that's it, right? So then you have a mom that may have lasting issues, I mean, even in that year period, that then she doesn't even have medical care to get herself seen about so that she can be healthy for her baby, right? And so I think there's definitely a lot of implications for policies of, making sure that we have a woman that is able and has access to the services that she can take care of herself so that then she can be a great parent for that baby as well. Those are just two things that come to mind.
I was going to say, too, just to add, I mean, Medicaid expansion is also a piece of that. I mean, there are still several states, particularly concentrated in the South, that have not expanded Medicaid. And so if all states were to expand Medicaid, we can get at some of those women that, with a higher income threshold to bring them into care, and have access to health care through that channel. I think also something else that we didn't talk a lot about today is access to mental health care, which I think is another piece of the puzzle here that impacts women across the spectrum. And so doing more to ensure that Black women have, access to screening for mental health care, and then also bringing them, having insurance coverage. Because that's a piece too. I mean, I know, I'm, a middle income woman, and, I wouldn't be able to afford to see a therapist when I needed one, paying for it out of pocket. And so I think that's a barrier in terms of women having access to mental health care and the costs associated with that. I just wanted to add too, rates of depression and stress are very high among Black women, higher than the general population. And so we definitely need to do more in that space. Yeah.
At least there's, oddly, in North Carolina, a beacon of hope. While they didn't expand Medicaid, they did change the Medicaid program to include home visits and dramatically reduce the maternal mortality rate. I mean, so things can be done.
And I want to also highlight North Carolina is actually, I don't know of any other state. I think there's some that are trying to replicate, but they're like one of the only states that has a postpartum inpatient for women who are having like any kind of psychiatric or mental health complications, and the mom can go there, she can get respite, her baby is not excluded from that. And so I think that is it's such an important point that both of you brought up. And just to kind of add on that, like making sure again, this is like policy changes that do need to happen, is that women do need to be seen earlier postpartum. Like having your baby being sent home 2 days after you've had that baby and nobody sees you, checks on you, is for 6 weeks, and that is one of the most ridiculous things I've ever heard. But we miss opportunities not just to assess her mental health, but opportunities where that woman may be having complications. And if we look at postpartum complications that result in either an adverse event such as death or a near miss, those usually happen in the first 1 or 2 weeks postpartum, right? And those are opportunities that I feel like intervention could have happened had we had different systems in place around postpartum. To answer your question about what to do on the other end, like the 0 to 3, I think, again, how do we engage providers in asking better questions? Mom is going to that first pediatric visit. The pediatrician should not just be focusing on baby. They should be asking mom, how are you doing? How is motherhood going? Do I need to do a mental health assessment? Am I trained to do that? And then I can connect and engage mom in that way. I feel like moms are interfacing with the system, but there's so many missed opportunities to assess her overall well-being.
I think another piece, and I know we have to close, is also access to affordable childcare.
Yes.
That's another piece too. I mean, people are spending, paying as much as they would spend per rent or a mortgage on childcare monthly, and I think that's another piece of the puzzle here, particularly when we talk about the economic implications. So we can do a couple more questions. So I think here.
One last thing really quickly. So going back to the infant piece and the mother piece, I think also no matter what the policy is, I think we have to be strategic in connecting the dots for the policymakers,
yes,
right?
Absolutely.
So we know policymakers care about babies. So then when we're pushing any sort of maternal health policy, showing them that connection is also powerful, always having it in their face. And even if it's a policy around specifically infant health, sliding the maternal health piece in there just so that whenever they see it, they see the two together, I think can be really impactful.
Hello, everybody. My name is Lafifia Lewis, and I'm a student at UCLA, and I'm currently doing a research fellowship here in Washington, D.C., and I'm interning at the Congressional Black Caucus Foundation. And my research interest is in the mass incarceration and its effects on Black women. And one thing that I've discovered in my research is that 4 of 9 women who enter the prison system are pregnant. And I'm just curious if there is any research being done on Black maternal mortality or just the criminality of motherhood in regards to Black women, and if there's any research that you've come across, and also if the numbers of the mortality rates, are they higher for women in prison?
Not sure. I don't know if the rates are higher, but we know the effect on we know about the effects on the children and mothers postpartum. There has been some research there. There are a few prisons that will allow the baby to stay for, depends, 30 to as many as 90 days, so the mom can bond with the baby, because that has shown that that child and the mother do much better. Reincarceration rates drop dramatically when the mom can bond with her baby. The baby, as he or she grows up, is less likely to be incarcerated. So there's some research around that, but I can't tell you about mortality rates. We'd have to look that up.
I know there's some stuff around shackling in birth, and there's been a lot of advocacy work around that, but yeah, I'm unaware of the same research that she's aware of.
Yeah, I don't know the numbers specifically. Speaking of the shackling piece, I think it's crazy. It's 2018, and we're still fighting this in states. Afterwards, I can give you my card and link you with some organizations. I mean, I would definitely point you in the direction of the National Advocates for Pregnant Women. They deal a lot with incarcerated women. I know that there are some great programs. There's one out in California that actually has formerly incarcerated women serving as doulas for women that are currently incarcerated. And then also just advocating for their right to breastfeed and things like that. I mean, so there is advocacy around this issue, but I think it goes back to just this notion that people assume that because a woman is incarcerated that she no longer has human rights and the right to parent her child. And to have a delivery and a birth with dignity. And so it is an issue. I don't think enough people are talking about it, but the conversation is happening. So I could definitely link you to some resources afterwards.
I think we have time for one more. I know this gentleman over here has had his hand up for a while.
Thank you. My name is David. A couple of quick comments and then a question. First question is, are you doing anything specific with the Black church in order to affect either the infant mortality or morbidity or maternal mortality or morbidity? That's the question. 2 quick comments. I think when you're thinking about pregnancy, you have to really look at 6 months prior to getting pregnant if it's a planned pregnancy. Because a lot of things that happen with Black women or poor women in general are environmental factors, and we have to address those. Secondly, I think we need to have our women advocate more. The reason that the white female higher level income gets more respect when they first seen is that that doctor, that individual knows if he does something that is abnormal with that person, they'll report them and they'll write. Many times our women who have low economic situations do not complain in writing or even verbally. So I think getting women to realize they have a right, I think that'll make a big difference in how those doctors react to them. I'll give the answer to my question now.
If anyone is working with churches in this space.
Not directly. Churches will sometimes offer resources to our organization, like in the form of food for our women who deal with food insecurity, and they're aware of the mission of the organization, but we're not doing any direct work within the church around this particular issue. And I do agree with your point around women being very aware of their reproductive rights, because we've seen when we've complained or had to go over someone's head, that quick change happens. So I agree.
add that I think there's value in women sharing their stories of what's happening, right? And I can't say enough about the value of having a doula and an advocate there with you. We did a similar screening in Atlanta last week, and there was a young lady that stood up and said that had she not seen the documentary, she didn't know that she wasn't supposed to be in severe pain when they were stitching her after she had an episiotomy. So it's like, well, if no one is sharing that with her, how would she have known that she wasn't supposed to be feeling that? And so I think that the more that we can have conversations like this and continue to amplify the story and share on social media or whatever the platform is, then we can let women know this is not a normal experience. These are your rights. You can complain. These are the avenues of how you can affect change. So I just wanted to share that.
I would say every church health ministry ought to have a screening.
Mm-hmm.
Yep.
Bring young women in and older women, because they often, the moms often will accompany their daughters. But they need to see this. They need to understand what is happening. We don't take bad service from the cable repair guy, but we'll take it from the OB, and that has to stop. We've got to demand the kind of health care, the kind of respect, the kind of value, the kind of treatment we deserve every time we see the provider, and take nothing less.
I have a quick question. I know we have to wrap up. I could talk to y'all all night, I will say. But something about the doulas came to mind, when you were talking, Breana, and our women in the education piece. So the women that, you all may be working with, do they know what a doula is and like the services they provide? And then also, what is your take on Medicaid reimbursement for doula services?
So we don't train doulas because this is my personal, right? I was trained as a doula, and I don't feel that doula training is adequate for the population that we serve. So doula training, as it presently exists, is a microwave model, and it's 2.5 days of training on average. And I don't believe that the levels of support, specifically addressing social determinants and the depth of the support that's needed, is what high needs communities. I think a doula is very appropriate for an upper income woman who may not have a lot of social determinants, but she really needs somebody to be there as an advocate. Like, it is very appropriate for that. But when you're talking about communities such as a lot of women that were featured on a documentary, like having somebody just come, and be there for your birth is not enough. It's like taking a homeless person on a luxurious vacation and then dropping them back off at the homeless shelter, right? Like, you still have all of these needs, and oftentimes doula training doesn't train the doula to even address those social determinants. Like, that's not even a part of the scope of practice for a doula. So I feel, and this is how we train the workers within our model, is more along a community health worker spectrum, because the community health worker has been a long-standing, very efficient public health model, and then adding in that perinatal specialty and giving them that depth as well as that scope of practice that not only will allow them to accompany her at her birth and be a supporter there in her birth, but that will also give her what she needs to address her social determinants on the prenatal and the postpartum side and follow that mom through 6 months postpartum. And then the other piece of that is sustainability of the workforce. So if, doulas, Black doulas are also marginalized, right? And it's hard for them to make a living wage. And so we've been able to contract with Medicaid managed care organizations in the district, and be able to give women, tap into a workforce that's not tapped into, which is the women that you're serving in the community. So tap into those women, provide them with skills, resources, education, knowledge, and they're their own advocates now, right? They're educating the woman next door and their cousin and their grandma and everybody else in the family. So Medicaid reimbursement, yes, but I do think if we do that, there has to be some standards of training, because then you recreate the same kind of model where there becomes a dichotomy in who gets served and who doesn't, and who's seen as valuable and who's not seen as valuable.
Add one last thing to that. I can't help but think about it. Number one, yes, community-based doulas should get paid phenomenal work, right? I think what we also have to constantly bring to the table with that, though, is to value it for the nature of the work that they do, because I always think about how we've had traditional midwives in the Black community for centuries, and then through the medicalization of the childbirth experience, suddenly it's a bad thing to go to a midwife that's not a certified nurse midwife, right? And so I just want to say that as we're exploring all of these policy opportunities to get doulas paid, because they should be, that we have to make sure that we have the right doulas at the table, and setting the policy such that 20 years from now, we don't look up and see that the Black doulas still aren't getting paid because there's some other sort of certification process that now they can't afford, can't go through. You know what I mean? So I just want to put that out there, that we have to be really careful when we start putting stipulations on the type of work. But
okay, well, we have to close. My colleagues are looking at me like, you know, come on. But thank you all so much for being here tonight. You know, I know that CAP, as well as my colleagues here, are going to continue to, you know, have conversations about this issue and make sure that Black women's voices are being heard in this space, and we come up with some solutions to help remedy the issue. So continue to track the work, and thank you all for coming tonight.